Tall buildings, big highways, comfortable homes, a car for every family. For years, these have been the symbols of modern life. But only a small part of the world's population can afford such a life. The same is true of health care. There are very few hospitals in developing countries where treatment is given free. These hospitals can't cope with the health needs of all the poor people in the cities. So much money has been poured into big hospitals and sophisticated equipment by governments all around the world that it affects the training of medical students. They learn their job on expensive equipment. They are trained more in curative than preventive medicine. Many of them aim to become specialists. Few are taught to concern themselves with basic health care. This kidney machine costs more than $10,000. One nurse has to be in attendance at all hours. This raises questions about the allocation of resources. So much technology, so many highly skilled people engaged in saving a few lives. So little money, so few qualified people involved in tackling basic health needs around the world. How can doctors and nurses use their skills for these wider needs? Small groups of doctors in several countries have begun seeking ways to do so. Bangladesh faces these problems as sharply as any country in the world. Health care is inadequate in its few big cities. It is even less adequate in rural areas. In Noakhali district, where 120,000 people live, there are 3 doctors at the health center. They do an important job in treating drastic cases, but they realize that a single district hospital will always be overcrowded. They also realize that since health care should consist more of preventive than curative work, it need not depend primarily on doctors and nurses. So they set out to train paramedical workers and to create a network of 5 sub-centers where there are clinics. There's a clinic within 2 miles of every home. These are run by an assistant nurse with clinic assistants who have only 5 weeks training before tackling work like malaria cases. They also run special clinics for children under 5, keeping a record of each child's health and giving immunization. At these clinics, they also supply a daily food supplement, wheat mixed with chickpea, to 4,000 young children. The assistants often visit women in their homes, giving advice on nutrition, immunizations, and family planning. A doctor isn't needed for any of these jobs, but he visits each sub-center twice a week for serious cases. Health cannot be studied as something separate in a community. It is linked to every aspect of development, to sanitation and clean water supplies, and to food production. Especially in countries where there is heavy population pressure on the land, health care depends very directly upon the people being able to make the most productive use of all the land available. Only in that way will large families be able to enjoy enough nutritious food. So how broad should the functions of a health worker be? There is no single answer. It is different between countries and within a single country. Panama is a country with 9,000 small communities scattered in the mountains and along jungle rivers. Each group of communities has to work out its own needs and how to tackle them. Near Cologne, a village began with a household survey, collecting facts on people of all ages. They paid particular concern to the growth and the state of health of the younger children. Members of the Community Health Committee, a cross-section of the villagers, analyzed the statistics from the survey. Then they held a meeting for the whole community, putting the facts before them. They heard people's concerns, and together they planned a community program of action. One measure they decided on with hospital officials and the medical officer who's in charge of public health in the province was to choose and train a medical assistant. The people elected their own medical assistant, Marciana Jorado, someone they knew could do the job they had just defined. She is trained at the district health center and goes back there once a week for further training and to get medical supplies. She is also trained how to move around the community, encouraging people in many efforts of self-improvement. She is mostly on her own and coping with a wide range of jobs that go beyond the normal boundaries of mother and child health care. For example, she advises on improvements to sanitation. In 3 years, 40 other assistants like Marciana have been selected and given basic training in Cologne, and they are now working as part of the provincial health team. In their villages, they are the health team, and something more important. They have shown the community what it can do once it starts to mobilize its own resources. In a very different culture in northeast Thailand, the medical faculty of Khon Kaen University asked officials in 16 provinces what was most wanted in healthcare. Back came the answer from the villages: someone nearby to consult when we are ill. So Dr. Kawi and his staff began simple training courses in 1975 for village health volunteers. Unlike Bangladesh and Panama, these are part-time health workers who earn their living by farming. Training courses are short, 2 or 3 weeks at a time, but they attend several courses over a period of 2 years. The university has found there is a need for more appropriate teaching materials for this new level of pupils. It makes do with some traditional equipment, but it does its utmost to give realistic training. The series of short courses should equip a village health worker with the skills to treat common illnesses. Mr. Michai, a farmer who lives 50 miles from Khon Kaen, treats malaria and diarrhea, gives advice on nutrition and family planning, and tells villagers how to protect themselves against parasites. He also knows when and how to refer difficult cases. The villagers appreciate Mr. Michai's work. They built a small clinic for him. In Canada also, some rural communities have shown they know best what they need in health care. A group of Indian leaders told health officials the best way was a broad educational approach. Health, they said, wasn't just a segment of somebody's life. It covered everything, from how and where they placed a house and found clean water supplies, to their daily food needs. In 1964, the Government of Canada began training community health representatives at Fort Qu'Appelle, Saskatchewan. Eugenie Lavalley was one of the first, working in her own Piapot Indian Reserve. As she explains, her job led her into teaching many things.
The minute I graduated from the fort, that was the first thing I did. I had to come and talked to the chief and then the nurse, and I had a very good nurse, I can say that much, because she was always out there. If I had a meeting, she was there, and that used to be a big lift, because at that time, even I belonged here, I was still afraid, you know. I needed somebody there to give me courage. I used to go by seasons, accidents in the winter, and, you know, in the spring it was x-rays for TB and stuff like that, and the cleanup. And then in July it used to be more or less gardening, and so in August it was judging of the gardens, and but everything pertaining to health is what, you know, what I worked on. On the long run, I think I made it, and I quit last year. Not rich at all, broke, but a lot of friends.
She has retired now, but is still very much involved in community affairs as an Indian band counselor and member of the school board. She has handed on her job on the health team to Violet Piapot. Violet works closely with the nurse who visits her clinic. The nurse gives immunizations. Violet keeps the health records of each child. She also spends time with the children in school, teaching them about a good balanced diet.
Oranges. You drink a lot of milk? Huh? Number 6. Really? Irma, you drink a lot of milk? Yeah. Cherries are not good for us.
Home visits, talking to people at leisure and in their own Cree language are a very important part of the community health representative's work.
Well, I was always interested in people. I think that was my main, maybe main reason. And towards the end, this is one of my biggest thrills, was visiting around. We used to talk about anything. I never put pressure on anybody unless it was urgent. You know, like I used to just more or less give them hello and talk about maybe the stars or something, you know, just anything. Just kind of break that ice. Go easy. And then advertising the clinic date, you know, mark their calendar and little things like that, and so they won't forget. So, you know, it's the trust and the confidence of the people that I think I always worked on first.
In Saskatchewan, they were told not to take people to hospitals except in an emergency. In Venezuela, they don't need to be told that. The distances for most people to any big hospital are too great. In the upper reaches of the Orinoco River, the rocks and rapids are a barrier to movement. But the river is still the main highway in southern Venezuela. Omania Prato, a medical auxiliary, visits his group of villages by dugout canoe, powered these days by a 30-horsepower outboard motor. He has had 6 months training, and he needs all that training to be self-reliant, because although the system of simplified medicine calls for regular supervision, in practice the size of the area is too large for a community nurse to cover thoroughly. He takes and checks malaria swabs in his clinic. He makes house-to-house visits around the villages. Many children suffer from malnutrition in the Amazoni's jungle area. He tries to treat such cases before the weakened child is infected with other diseases. Back in his home village, he calls the people for a general talk on hygiene. It is 60 miles by river, past many rapids, to the regional hospital at Puerto Ayacucho. Only the worst cases of emergency are taken there. The child needing a blood transfusion. The baby who has been born months premature. Iran is a final example of these trends in healthcare. It has 12,000 doctors, but half of them practice in the capital, Tehran, and most of the rest work in other big towns. Yet 20 million people still live in rugged countryside, and there are some 20,000 villages of less than 100 population. How can a country provide an effective system of health care for these small, scattered communities? Dr. Hussein Ronaghi of Pahlavi University had a plan in 1972 for a new level of health worker.
We thought that we can do some of the primary health work by the villagers themselves, train them in the village and deploy them in the village working as a health worker. This was an experimental program, something similar to Barefoot Doctors of China, but in different socio-economic and political situation such as Iran. What are the health needs of Iran? What are the basic health needs of Iran? And do we need really a major center with all multi-specialty clinic and multi-specialty, or can we spend our money and have our priority in the villages which has the basic health problem, upper respiratory tract infection in the winter and diarrhea in the summer? These are two major killers in 2 seasons. By only treating these two major problems and improving the nutritional status of the children, we have certainly contributed a lot to the health of our population.
Mrs. Bordar is one of 46 literate villagers in Fars province who trained for 6 months in a health center. Back in her village, she makes home visits to give advice on hygiene and sanitation. She also inspects water supplies. She believes in teaching good health habits to all ages, but especially to the young. So she often gives talks in the school.
With 33 million population of Iran, we have only a pool of 12,000 physicians. Even if we would have enough physicians, even if we would have 60,000 physicians, they would not probably be suitable for that kind of situation of a community of 100. So there would be no choice but to create a kind of manpower socially, economically, and mentally suitable for that kind of community.
The village health worker is the first level in the health care system. Second comes the Bedar, who has had 4 years training. Then the physician at the health corps station. And finally the hospital. Dr. Ronicky explains.
What we have done is to create a system which starts from the village, which has VHW, village health worker, taking care of preventive measures and doing some therapeutic work in major and most important disease. Then they would refer the complicated cases to upper level, which is called Bedar. Bedar would do at least 90% of the problem and refer the 10% of the problem to the health center, which is equipped by a physician. This is a health corps system which has 400 different posts all over Iran, and these are by young physicians who are doing their military work for 2 years in the villages. Whenever there is a complicated case, which I would believe is less than 1% of the cases, we can refer them to university hospital. And this is the idea of having the village health worker, Bedar, health corps physician, and university hospital as a comprehensive health care for the entire nation.
There are still only a few village health workers in Iran, but these few have proved their worth. Village health workers are only part of a total health system, in Iran or elsewhere, but they can be the foundation block upon which the whole pyramid is built. If it is to be a solid structure, there must be a good way for one level to supervise the work of the level below. And it must be easy for workers at any level to put forward ideas about changes that can help improve the whole structure. The village health workers, being closest to the people, have a voice that should be heard. These are only 6 examples of trends in rural health care. Other countries will find their own ways, drawing on their own traditions, but seeking the same goal, a better life for all their people.